Hi, I'm Helmy Eltoukhy, co-founder and CEO of Guardant Health. First of all, I would like to thank PMWC for their support in putting together this program. Welcome to our session on current and future implications of COVID-19 on cancer care and screening. COVID-19 has fundamentally disrupted cancer care, shifting care onto virtual platforms and rearranging clinical practice and research. The pandemic has also disrupted preventative cancer care during the peak of the first wave, whereby screenings fell precipitously as they were largely classified as non-essential healthcare procedures. Through this initial disruption, providers have adopted new workflows and new technologies, among them a larger embrace of telemedicine, all of which are likely to have positive ramifications that last long after the pandemic has subsided. We are fortunate that we are joined here today by an esteemed panel to delve deeper into these topics. First, I would like to introduce Dr. Pelin Cinar, who is a specialist in gastrointestinal oncology and the director of quality improvement at the UCSF Cancer Center. Next, I would like to introduce Dr. Laurie Glimcher, who is the president and CEO of the Dana-Farber Cancer Institute and director of the Dana-Farber/Harvard Cancer Center, and the Richard and Susan Smith Professor of Medicine at Harvard Medical School. Next is Dr. Laura Esserman, a surgeon and breast cancer oncologist and co-lead of the breast cancer oncology program at the UCSF Cancer Center, as well as a professor of surgery and radiology at UCSF. And she's also a pioneer of the innovative ISPY Trial. Last but not least is Dr. Mark Fleury, who is a policy principal for emerging science at the American Cancer Society Cancer Action Network. Mark specializes in research, drug development, and regulatory policies, and sits on the steering committee of the TAPER program. Now I'll invite each of our panelists to spend a few minutes giving us a highlight of their views on COVID's impact on cancer care. Let's start with Dr. Cinar. Thanks.
Thank you, Dr. Eltoukhy. I'd like to share just a few slides of our experience at UCSF, as well as some of our colleagues. Early months of the pandemic really provided us with a lot of uncertainties that caused a lot of anxiety in both our patients and our team members. And the key question that we came up during that time period was really, how do we continue to provide compassionate, high quality care for all of our patients while we prioritize safety for our patients as well as our healthcare workers? This, of course, in the setting of limited resources that the East Coast especially was experiencing, provided us to really be adaptive and come up with guidelines and protocols, as you mentioned, to be able to continue to care that we were used to providing for our patients. Early on, we had multidisciplinary teams come together and do an evidence-based review in the setting of limited resources. And the care patterns in both medical radiation oncology as well as gynecologic and surgical oncology via multidisciplinary discussions were brought up and essentially search plans were put into place. We were very fortunate to not have to go through that, mostly because I believe the Bay Area was able to implement shelter in place early on, as well as most of California. But nevertheless, we were able to provide some of our patients with less frequency of coming into the cancer center by increasing the intervals between regimens, if that was possible, and there was evidence supporting that. Some regimens that were infusional chemotherapies were converted to oral oncolytics. In radiation oncology, we were able to perhaps provide shorter courses of radiation therapy when there was evidence supporting this. And in surgical oncology, with the help of a multidisciplinary team discussion, perhaps implementation of neoadjuvant chemotherapy or systemic therapy or radiation therapy was implemented. All of these guidelines and algorithms really allowed us to continue to provide the high quality care for our patients. One thing I think that was a challenge early on in the pandemic was the fact that we didn't allow any visitors, and that actually continues to be the case in a limited way. And this caused some concern in our patients who really wanted their loved ones, their care providers, to be able to accommodate post-operative recovery time to be with them. And we tried to address that to the best possible way. And as you mentioned, telehealth became an integral part of how we continue to care for our patients. At UCSF, we had about 8% of our volume, total visits, contributed to telehealth prior to the pandemic. And this peaked in April to about 76% of our total encounters being delivered via telehealth. And that included video and telephone visits. And since then, it's been around 55% of our visits that are delivered through telehealth. This time period really allowed us to determine what the benefits of telehealth was, and there were many. It increased access to many of our patients, and this included patients who were driving from hours away who now didn't have to come into the cancer center to be seen by their providers. It also allowed care providers to be able to engage in the discussions, perhaps even care providers and family members from out of state who were able to call into the meetings. It also improved some of our workflows. Our MA ratio for rooming patients is about 14 patients per day, and this was actually around 30 patients who were able to undergo intake for telehealth visits. While we had these improvements, it was undeniable that there were also challenges. Many of our patients were unable to get this, whether they didn't have access to the technology, they didn't have smartphones, computers, or even access to high stream internet services. There were also our patients with limited English proficiency, where telehealth may become quite more challenging to be able to communicate effectively. And the concept of website manners came about, similar to bedside manners. So providers who had never done telehealth visits previously to this had to learn how to essentially communicate via a video or a telephone in an effective manner, especially in oncology, where we often have to give bad news to our patients. And that also brings us to healthcare inequity in the pandemic era. We know that there is healthcare inequity pre-pandemic, and this, I believe, exponentially increased during the pandemic. What we saw in the general population was that minority populations are more likely to hold low-income jobs. That doesn't perhaps allow for healthcare coverage, so access is an issue. We know that early on they were unable to have they had structural barriers to be able to get tested. And we also saw that the Latinx population, as well as the Black population in the general population, had a higher incidence of COVID-19, higher hospitalization rate. And when ASCO Cancer Link shared their data, we actually saw that patients with the group of Latinx Black patient population with cancer also were more likely to diagnose with COVID-19, up to 5 times higher in the Latinx population. And the Mount Sinai data also made us realize that telehealth, as we expected, was less likely to be accessed by the Black and Hispanic population. So certainly a lot of lessons that were learned during the pandemic, and I look forward to the panel discussion that is to follow. Thank you.
Thank you so much, Doctor. Let me just turn over to Dr. Glimcher to give her insights on what happened at Dana-Farber and elsewhere.
Thank you. It's a pleasure to be here, and I thank you for inviting me. Well, I think, as everybody knows, the COVID impact on cancer patients and cancer care have been dramatic. COVID-19 obviously poses a special risk to cancer patients because their immune systems are weakened against infection when they're in active chemotherapy or they're taking medications that weaken their immune system. So they are at special risk, but that doesn't mean that we can just stop treating cancer patients, because cancer does not stop because we happen to be in a pandemic. But we did, as you just heard from the previous speaker, there are things that one can do to try to limit the amount of time that a cancer patient has to spend inpatient or in-house. And whenever possible, one can try to switch the regimens such that we can avoid bone marrow transplants in some cases by putting patients on oral medication. But, you know, patients who need to come in to get their infusions, their chemotherapy, must come in. And so actually the number of infusions that we did dropped by only about 15%. But we used telemedicine as was previously described, and I won't repeat that. What I found particularly scary is that the patient volume decreased and the new patient volume decreased by substantial amounts because people were not getting their routine screenings, such as, mammograms, colonoscopies, pap smears. That actually dropped by more than 90% during this time. And so cancer diagnoses dropped by nearly 50%. And that's very worrisome, because obviously if you can catch a cancer early, you've got a much better chance of treating it successfully. Only 25% of patients present in stage 1 cancer. 75% present later on, and they are more difficult to treat. And a comment from the National Cancer Institute Director, Ned Sharpless, was interesting. He estimated that this impact on screening and treatment for breast cancer, colorectal cancer, cervical cancer probably is going to lead to an additional 10,000 deaths over the next decade, which is very alarming and troubling. So of course, we took action very early in the pandemic. Within the first few weeks, we went from doing 10 to 15 telemedicine visits a week to 3,000 telemedicine visits a week. And we took a number of steps to really ensure that the environment was safe in the clinic for patients who needed to be on site. And I've had patients say to me, we feel safer at Dana-Farber than we do anyplace else except in our own homes. We have been encouraging people over the last many months. We've been working hard to encourage more people to resume these routine screenings. Go see your primary care doc, and then seek care if you need it. And as I said, we've implemented many operational initiatives to provide a safe environment for our workforce and for our patients, to assure them that we're delivering the best cancer care possible in a very, very safe environment. And this is particularly important because of the rising cancer incidence among young adults, which is very alarming. I mean, half of all Americans are at risk of developing some form of cancer in their lifetime, but we are seeing an alarming trend of rising cancer incidence among younger patients. One example that's particularly obvious is young onset colorectal cancer. I have seen several patients coming in their 30s and early 40s with metastatic colorectal cancer. This is very scary, and this actually stirred us to found the Colorectal Young Adult Onset Colorectal Cancer Center at Dana-Farber. There was a recent study from JAMA that found that the rate of cancer in adolescents and young adults has increased by nearly 30% since 1973. And that includes stomach cancer, it includes esophageal cancer, it includes colorectal cancer, and a relative increase in carcinomas. Those are cancers that originate in cells such as skin or tissue lining inner organs. So this is very scary, and we need to work even harder in our laboratories to figure out why this is happening, and then what we can do to prevent, treat, and manage more cancers in younger people. We spent a lot of time supporting our frontline staff and faculty. And thank God, we have a vaccine, 2 vaccines now for COVID-19, with 2 more, which will probably be available in January and February, one from Johnson & Johnson and one from AstraZeneca. And the 2 we have, of course, are the one from Pfizer and the one from Moderna. But we have not ceased our clinical trials. The one good part of this was that we did not have to stop our clinical trials for cancer patients, whereas clinical trials for virtually every other disease were halted. At Dana-Farber, we were able to keep our clinical trials going on, continue enrolling patients. We had very few dropouts of patients. And this is so critical because for 20% of our patients, their best option is a clinical trial. We just started vaccinating our clinical and non-clinical patient-facing staff members. We've delivered over, I think, probably by now, 1,500 vaccines, the Pfizer vaccine. But, you know, the incredible effort that everybody has put in and the sustained vigilance does come at a cost. And I have to say, there's a real sense of fatigue across our frontline patient-facing healthcare workers, including some well-documented burnout among faculty, notably young women who also have children at home and are trying to juggle children who are learning at home and carrying out their very intense jobs at Dana-Farber. So this pandemic has taken a real toll on working mothers, including those in science and medicine, and unfortunately has forced many women out of the workforce. And that's incredibly worrying to me because it not only robs us of the brain power we need today, but it's going to jeopardize decades of progress towards work and economic equality. So we've been doing a great deal of work to support everyone on our staff and connect them with resources that can help during this difficult time, childcare, well-being, and so forth. But I know there's more we can and must do to support women in science and medicine today, and to ensure that we're intervening at the right moments in their careers to keep women not only in their careers, but advancing in their careers. So I'm highly encouraged about the COVID vaccines that are now available, but I'm still very deeply concerned about the scarcity of effective treatments for already infected patients. And frankly, despite many tries and many clinical trials, the only drug that has been found to be effective is dexamethasone. Remdesivir has a very, very moderate improvement in the length of the course of the infection, but you know, it's not all that effective. So the FDA has granted, as you may know, emergency use authorization for monoclonal antibody treatments produced by Regeneron and Eli Lilly. And a company called Vir is also is entering phase 3 clinical trials. These treatments are still very scarce, and they're really meant only for patients who are at risk of being sick enough to be hospitalized. So I think we need to continue our search for solutions to ensure that an infected patient who would benefit from this treatment actually has access to them, especially now with cases being at their highest numbers since the beginning of the pandemic. And this extends in particular, as you heard from the previous panelist, that cancer equity has failed here. More than twice, Black Americans and Latinx Americans die at twice the rate of white patients who are infected with COVID-19. That is simply unacceptable. And so we've also spent a lot of time at Dana-Farber trying to reverse that inequity and providing access to every patient who needs us. And I'll stop there.
Thank you, Dr. Glimcher. It's fascinating. There's so many dimensions to this pandemic. It's, you know, you can go into so many different areas, and it'll really be interesting to see what the ramifications are going forward. You know, speaking of trials, I'll turn it over to Dr. Esserman to give us an overview of some of the innovative work she's doing during COVID.
Thanks so much for having me. And I want to provide maybe a complementary perspective, and really maybe focus on the things that we can learn, and maybe some of the things that this crisis has enabled in terms of our sense of urgency and ability to act. As a surgeon, and as I run our multidisciplinary breast cancer program, you know, at the beginning when the operating rooms were shut down and we had to be creative in thinking about how to manage patients. So, you know, one of the important lessons, of course, is that this is the Personalized Medicine World Conference. So again, one size doesn't fit all. And the whole idea of being able to tailor treatments to biology is critical. But some operating first actually robs you of your ability to understand how people respond. And sort of moving our treatments for early stage patients from the surgery first, then adjuvant therapy, moving it to the neoadjuvant setting is something we've been trying to push for well over a decade. And the pandemic actually really sort of forced people more into that, especially as the operating rooms were closed. People had to be thoughtful about, well, is this really a crisis? Well, no, start with neoadjuvant therapy. If you have a cancer that's lethal and needs systemic therapy, you're better off starting with that first so that you understand what that person's response is and that you know whether they need more and whether they need less. And that is, that's really critical. That's true for DCIS. For a lot of these early cancers, maybe we're over-treating. And, I want to bring a perspective about cancer screening. Now more than ever, it's essential to know, does everyone need to be treated the same? Does one size really fits all? And the Wisdom study is a large breast cancer screening trial that we're running across the country, funded by PCORI and now the NCI. Really, and we now have 32,000 women, and 5,000 women signed up because it's actually all online during the pandemic. And isn't it critical to know if you have low risk, screening every other year like they do in Europe and almost every other country outside of the US is probably quite appropriate. And if you are at high risk, well, then you would know, despite the pandemic, you ought to come in. And I think people need to understand that there are harms from screening. There's the chance of overdiagnosis, there's a chance of biopsies, and particularly in the pandemic, you don't need to be coming in for extra things if you don't need it. And, we've discovered through our active surveillance program that probably 2/3 of patients with DCIS may be able to be treated with neoadjuvant hormone therapy or endocrine therapies, and maybe they're not amenable to surgical therapy because they're really about background risk. These are the things we have to understand. And the family of ISPY trials that we've organized really is about trying to understand, well, who needs what? The idea of this trial was originally started in the cooperative groups, and then we worked with the FDA and the NCI and the Foundation for the NIH, and then moved this into and now is sponsored by Quantum Leap Healthcare Collaborative, a not-for-profit organization, to try and bring all the institutions together in a more efficient way. Again, bringing drug development earlier, because we do know that many of the drugs that either do work or don't work late may not be the right drugs early. We know some of the immunotherapies don't work that well late, but they work really well early. And, we didn't shut down the ISPY trial, which is across now 20 plus sites, because as Dr. Glimcher said, a trial option is actually better care in many circumstances than standard care. And, the idea of trials that say, I'm going to have an early endpoint, that is your ability to make the tumor go away before you get to surgery, that complete response is your early endpoint, helps you learn more quickly. And you can learn as you go, not a frequentist method where you say, okay, I'm going to enroll 1,000 patients. You can say, no, I'm going to learn. And when it reaches, in a Bayesian framework, you're learning as you go. When you reach a threshold for graduation, then it can graduate. But if it looks like it's futile, don't waste a bunch of patients, you stop. And these are, we have screened 22 drugs or combinations in the ISPY trial, in less than 10 years, with the idea that we're trying to find those drugs or those agents that have the biggest signal. You may miss a few that might have a small impact, but it's an opportunity cost, right? You don't want to waste time on, you just have to make a choice. We are lucky, the PD-1 inhibitors turned out to be a home run. They triple the chance that these tumors are going to go away. They're not without risk. And the other thing is we were able to identify which subsets of tumors work and is helping us to really change the way we classify tumors. Now, interestingly, we were asked by the FDA and to think about taking this model and standing up a phase 2 screening trial for COVID. It turns out that one of the pulmonary critical care physicians, Carolyn Calfee, had spent a year sabbatical with me last year. And when the opportunity came up, I said, well, now's your time. If ever there was a time to run a trial, this is it. And again, like cancer, COVID is not one size fits all. The vast majority of people don't get that sick. But the critical thing we have to solve is we have to solve this problem for the people who do get critically ill. And we still don't understand exactly why people get that ill. But the idea is, can we find new treatments for the people who are critically ill? And it does shine a harsh light on the fact that we have ignored things like ARDS and antibiotic resistance because they're not necessarily big money makers. But in fact, this is all about national security and public safety. So finding an answer here is critical. And so you think about it, we are now running, we have about 450 patients in the trial. We now have like 15 sites and we're growing like every week. And we have now 8 to 10 agents in our pipeline that look really promising. And we assume that the pandemic will end in the late spring. And we hope we can get through all of these and find what are the big signals. And, Laurie's right. All we found is steroids. Really, our backbone is steroids and remdesivir, but there are a lot of promising agents out there and they deserve their day in court. And we need to look in an efficient way, common control, rapidly moving drugs in and out, looking for time, a big signal on time to recovery. And I think what I've learned over the pandemic is, that, getting people to move and change the way they do things, business as usual, wasting time, taking 6 months to get a trial up, it just doesn't work. The time to get it up is 3 weeks. So you need pharma to cooperate, you need the FDA to cooperate, and you need all the sites to cooperate. And I think it shows all of the glaring errors that we have, that you don't want to be unsafe, but you don't want to waste time on things that actually don't add value. People are dying, 3,000 people are dying a day, so, and we don't have something for it. You have to move at a pace, that the pandemic demands. And, you can't, so getting a common IRB, finding ways to get the trials to the sites that don't basically have the infrastructure, and standing up and doing it in that way is absolutely critical. And I would say the place where we have the poorest infrastructure is we don't have a common system where you could get a trial and everyone could stand it up, in 2 weeks or 3 weeks. It is a big deal for academic centers, for community centers, and people without resources to get these trials standing up. So we all need to look to ourselves to say, how do we change that infrastructure and allow ourselves to be more efficient when it's demanded? And I think the most important lesson we can learn is that sense of urgency to solve problems should not go away. And, COVID isn't the only thing that kills people. Cancer does too. And the time that we take and the slowness we have for standing things up and learning and moving quickly, that we have to stop doing business as usual and have, get that passion and insist on being able to do things faster. And integrating care and research, having systems that allow you to capture data in the course of care that you need for care, for quality improvement, and for research. This is actually one of the opportunities we're rolling out the system, what we call OneSource. So the idea is that you have a checklist in the ICU, you roll it out on an iPad, you collect it, that's your data for your trial. These Bayesian trials require data in real time. In spite of the pandemic, we have a 92% real-time data collection complete because we're able to do it that way. So I was able to take that 10 years of learning and apply it in about 4 months to this new setting. Still not good enough. We still have a lot of work to do, but it's better. And I think we want to take those kinds of ideas and bring them back to our cancer space and make sure that we are going at the pace, that the diseases demand, because our patients don't have 10 years to wait for us to get our act together.
Great. Yeah, thank you. Thank you, Dr. Esserman. I mean, that would certainly be a silver lining if we could take that sense of urgency from this whole situation and carry it forward in so many different areas of medicine. Dr. Fleury, turning to you now, and thank you.
Thank you. Thank you for the chance to talk about some of ACS CAN's work, and really honored to be on a panel with so many esteemed colleagues. I think Dr. Esserman really stated it well, and is a great segue to some of the things I want to talk about in terms of maintaining that urgency to innovate on behalf of patients. I wanted to talk just briefly about some survey results that we had collected over the summer that revealed some patient experiences during this pandemic. And many of the things that we found are things that you've already heard from some of the other panelists, that reported changes in appointments. But what our survey allowed us to do was also not understand sort of what changed, but sort of what drove those changes and what drove those patient decisions and some of the other aspects that they're facing. So it turns out we had stood up a survey cohort about a year ago to survey cancer patients and recent survivors on their experiences and perspectives. And with this survey cohort up, along came the COVID pandemic, and we were well poised to really quickly get our finger on the pulse of those patient experiences. So we fielded 4 surveys in total from May through August of this year, and have been able to really both track some of the evolution of the patient experiences, but also to explore different topics within the patient experience. So obviously we know there's been a tremendous impact on cancer patients from things like delayed or missed appointments, changes in modality. You've heard some of that already. But we know that the impact these cancer patients and survivors are not just defined by their cancer, but they're suffering from other things as well, like financial instability, emotional well-being, like the rest of us. So I won't spend too much time on the sort of impacts to direct cancer care. You've heard a lot of that from some of my colleagues who run cancer programs. But what we found is between 35 and 44% of patients reported having their cancer-related care impacted. Now that's any aspect of their cancer-related care, but between 9 and 17% of our respondents said that their actual anti-cancer treatment, so that is radiation or chemotherapy, was affected. And obviously, cancer patients often have other comorbidities. And when we asked about care in general, not just restricted to cancer care, that number went up to over 3/4 of all patients and survivors reported impacts to their care. In some cases, those were cancellation or delays. But as mentioned before, we saw a huge shift to telemedicine. Interestingly, a few months before the pandemic hit, we had done a survey of our cancer patients and survivors, and fewer than 2% had reported ever using a video visit. Well, fast forward to today, and the majority of our cancer patients have had to switch to at least some of their appointments being telemedicine. So when we think about the policy implications, we need to understand both the policy and the infrastructure to make that possible going forward. Now, we also, one of my focus areas is clinical research, and you've heard some of the impacts, or fortunately, some of the lack of impacts reported by the other panelists on their clinical trials. But we do know that in many sites, they stopped accruing patients to cancer clinical trials altogether. And a lot of that was due to the fact that sites were closed, or they considered clinical trial visits non-essential. One of the things that we asked ourselves is, if sites open up, would patients come back and be equally willing to enroll in a clinical trial? And we were able to embed some of those questions into a survey in the summer when infections and transmission had experienced a little bit of a dip. Importantly, what we found is that nearly 1 in 5 respondents to the survey said that the pandemic made them less likely to enroll in a clinical trial. So I think what's important here is that their concerns were they didn't want to come in more often than they had to for their treatment, and they saw coming in for a clinical trial as something that was optional. So again, understanding that patient decision-making may be driving some barriers in the future. And even with regards to general care outside of a clinical trial, when we asked those patients what was the source of the delays or cancellations that they experienced, understandably, a little bit over half of those delays or cancellations were simply due to a facility closure. They couldn't go in because the site was closed. But 1/4 of those delays or cancellations were initiated voluntarily by the patients because they had concerns about the coronavirus exposure. And even more, 30% were decisions by the providers who just told their patients, you know, maybe you shouldn't come in right now. We'll wait and see what happens. So again, I think it's really important to understand that not only do we need to address whether or not sites are open, but patients and their providers need to feel comfortable to have folks come in. Now that's a little bit about sort of the actual impact of the pandemic on cancer care, but we also asked a lot of questions about folks' financial well-being. And almost half, we had 46% of cancer patients and survivors said that their financial situation had changed during the pandemic in such a way that it was affecting their ability to pay for care. We know that millions of individuals have lost their employee-sponsored health care because of furloughs and layoffs. And in our survey, 1/3 of the respondents reported concern about just paying for basics. So this is food, mortgage, and things like that. We were able to stratify that by income. It went up to over 54% for those making under $30,000. So again, this just goes back to the idea it's not just about having sites open and creating a safe space for the patients to come in, but patients are losing their insurance or they can't afford the copays, and so they're making decisions to not come in. And so this really gets into some of the policy implications to make sure that we can maintain insurance coverage for cancer patients. And the last thing from the survey that I wanted to share was sort of the concern. 3/4 of patients in active treatment either agreed or strongly agreed with the statement that as a cancer patient or survivor, I'm worried about my ability to stay safe if COVID-19 increases. And again, half reported adverse impact on their emotional or mental well-being. So, you know, we need to understand that the cancer patient is more than a tumor or a cancer. They're a person who has stresses and other life concerns and financial challenges. So as we think about policy solutions, they need to go beyond the hospital and encompass insurance and emotional well-being. So I just wanted to close with a few comments, and I think they were raised quite well by Dr. Cinar about disparities. We've seen a swift change in modalities, the way that we deliver both normal care as well as clinical trials. And I think there's been a great deal of excitement about keeping some of these innovations in the way they can expand access for folks. But we also need to understand quite clearly how they impact the various subgroups, that not everybody is going to embrace these, either because of you know, it's just they would prefer to see a doctor in person, or it could be because they don't have the technology or the connectivity that they need for some of these virtual modalities that have been discussed. So one of the last things that we hope to do with our survey in early spring is to really dig into some of these decentralized modalities and understand how they might impact patients differentially, so that as we go forward, let's go forward and innovate, but realize that we might have to adjust and modify to make sure that we're not inadvertently creating new disparities with some of these new innovations.
That's great. Thank you, Dr. Fleury. It's a fantastic overview by all of the panelists. Let's maybe move into some questions and answers here. First question, for maybe start with Dr. Cinar and then move on to Dr. Glimcher, and then everyone else can jump in if you have something to add. First question is, in what ways do you think cancer screening and oncology care will look different, post-COVID? Obviously, it's hard to think about that now. We're in the midst of obviously a terrible situation with, the number of deaths we're seeing. But, obviously there's a light at the end of the tunnel here with the vaccine, hopefully that gets distributed and gets ramped up. And so kind of delving into that question, do you think that COVID and post-COVID, this will kind of catalyze further efficiency improvements, further decentralization of care? Or do you believe that the pendulum is going to swing back, so to speak, and go back to where things were in the future? So maybe Dr. Cinar, I'll start with you.
Sure. Yeah, thank you for that question. I think that's a big question on everybody's mind. And I think a lot of institutions are now using the term recovery, which in essence means you go back to how things were in the past. But I think that there's a tremendous opportunity here for all the lessons that we've learned and everything that my colleagues have mentioned. We have shown ourselves that we're adaptable. And that we can be a lot more efficient. As Dr. Esserman said, certain things would take us months to years to implement. And yet during COVID, when we all came together and had a unified vision, we were able to implement interventions within days to weeks. And that was just fantastic to see. So I hope that we can continue with the same energy and motivation for our patients. Yeah, so I sure hope that we don't go back to how things were before. I sure hope that we can learn and continue to evolve. To Dr. Fleury's point, I think we have to keep learning, and I think we have to keep becoming more efficient and just better at what we do.
I think we learned a lot during COVID-19. If there's any silver lining, we've learned that probably half of our institution can work remotely and do just as good a job as if they were coming in to the institution. And that's very good. It gives you more flexibility. You don't waste time in transportation. That's true for our patients as well. Some of our patients can be seen virtually, and we can collect the family that we like to put around our patients, the oncologist, the surgeon, the radiation oncologist, the nutritionist, the social worker. We come together and we have a virtual visit with all of those people. And they feel like they're surrounded by a family. It's not a substitute for coming in physically. But it can work very, very well for some appointments. We've also learned that we need to focus on high-risk patients. And, we have now really dedicated ourselves to the whole field of cancer prevention, early detection, and assessment of minimal residual disease. And, 10% of cancers are inherited. We need to be screening the relatives of anybody who comes in with an inherited cancer center. That's not just BRCA, that's Lynch syndrome and other syndromes. And we need to be working. We know that the most astounding thing we can do for cancer to reduce its incidence and to cure it is to detect it early. And so that has changed our priority somewhat at the Farber as well, putting more time into doing that. And high-risk people, it's not just the genetics, it's also some behavioral issues, smoking, most recently obesity, which is probably going to supplant tobacco as a major risk factor, and other ways to look for cancer early. I don't disagree with Dr. Esserman that we may be overdoing screening. That is possible, and that should be more focused on people who really need it because they're high risk. So we're not going to go back to where we were. We've learned a lot.
So maybe a follow-up question for Dr. Cinar and Dr. Glimcher. You guys were at 8%, I think, telemedicine at UCSF, beforehand, and it sounded like there was just a few telemedicine visits, before the pandemic. Where do you guys think you'll be, let's say 2 or 3 years from now?
I think we'll probably be around 55%. As Dr. Glimcher said, certain appointments are appropriate for remote visits, but there are certainly some that we have to do in person when patient requires examination, or it's a difficult conversation that we prefer to have in person. But I believe that we're going to probably be around 50% or so to be able to also increase access to remote locations for our patients.
We went from 10 a week to 3,000 a week, and right now we're down to about 1,500 a week. It's about half and half, as Dr. Cinar said. I think moving forward, cancer is a scary disease, and it's really important to see patients in person, certainly at the beginning of their treatments. And of course, they do need to come in to get their infusions, chemotherapy or immunotherapy. My guess is we will be somewhere around 30 to 50% in future.
Can I add something, Helmy, too?
Yeah,
I want to say that I think that the pandemic is like, it required people to really think about what we already knew and forced people to adopt new things that they had heretofore perhaps not been so excited about. Using a 3-week course or a 5-day course instead of a 6-week course for radiation. Why have additional benefits? Additional visits that cause risk when in fact the data say that. And sometimes we're not so quick to adopt new things. And people need a catalyst to force them to sort of think about the data and do what's more patient-centered and what's better. And that's actually something I think for all of us as a challenge, I would say, we need to also work on making sure that in the future that our reimbursement strategies come into alignment with what is patient-centered and what is scientifically driven, what is best for patients. Sometimes we get into a situation where the strategies drive us to do things that perhaps aren't as patient-centered. And I would agree with Laurie about screening is that, the whole idea of the wisdom study is to try and compare personalized screening versus an annual screening, the one-size-fits-all approach. Whereas you're doing all the genetic testing on everyone, population level, looking at SNPs, the study, Helmy, and trying to say, put it into an algorithm to say, well, who's at risk? Because the mutation carriers are few and far between, but the people at high risk, those 5% or 10% of people should perhaps come in more, but the rest we can do less. And you don't want to find a bunch of extra things on low risk people. That's coming in, that's exposure, whether it's, COVID or not. These are things we need to think about. The whole idea of personalized medicine means that we have to change. If you want to do more for the people that need it, we also have to be willing to say, let's do less for the people that don't. And I think that's, I hope that this pandemic will drive us in that direction. And just as they said, if you can see someone remotely, great. I'm not going to see my post-op patients that way, obviously, or I'm not going to, people want to see their surgeon before they go to the OR. They should, and you have to examine someone. But there's a lot of stuff that we, even in our ISPY trials, we cut our in-person required visits in half. Again, it's forcing you to say, do I really need this? Well, maybe I don't. And has anything bad happened because of it? No. So all those things will stay. And that's the thing that, we have to keep first and foremost and not allow ourselves to go back to business as usual.
No, that's well said. Well said. Anyone who can use the word Bayesian to kind of has a special place in my heart, being an engineer. So maybe Mark, when we end with like one last question, like what is kind of the major take home, from this? Like, let's say we have, God forbid, another pandemic in a few years. What would we do differently next time around?
Wow, that's a big question. I think obviously there's a lot of impacts to the cancer care ecosystems and cancer patients specifically that are really due to the pandemic itself. And so obviously, I don't think anybody would say that, we really aggressively address this pandemic. So I think we can sort of come up with workarounds to try and get cancer patients screening and treatment, I think, but ultimately, if we want to avoid the impacts that we saw today, we're going to have to be more aggressive about addressing the pandemic. But that being said, I think as others have mentioned here, I think we've learned that we can do some of these decentralized care techniques. And I can say, having gone to conferences, in person like this one in years past, I think we've talked about for years about, gee, wouldn't it be nice if one day we could do, this clinical trial with telemedicine or shipping the drugs to patients' home, or gee, wouldn't it be nice? That's all I ever heard was, gee, wouldn't it be nice? And now suddenly, because the pressure's been on, we've learned how to do it. And so I think leaving the pandemic, the question is no longer sort of, do we have the tools and the ability to do it, but do we have sort of the political will and the business case to continue to do it? And as I mentioned before, I think we've got to get the policy right. There's been certainly FDA and NCI from a clinical research standpoint anyway, have given a lot of flexibilities to use some of these decentralized techniques that ordinarily weren't there. And I think everybody is agreeing that most of these flexibilities will stay in one shape, form, or another. But again, I think it's important that we get them right. We have attention to folks who may have barriers to using some of these new techniques. But I do think we're going to learn a lot, as was mentioned before, about de-escalation of treatments. There's a million natural experiments going on right now. So I think it's critical that we take the time to analyze the outcomes of those and apply those lessons for the next time around, which let's hope doesn't happen anytime soon. Well,
I think, as Bill Gates has said for years, the most dangerous diseases ever are the infectious diseases, and we don't have enough antibiotics to treat those bacterial infections. And there's certainly going to be another COVID number 3 at some point. It's inevitable. So one of the things that I think this highlights is the need to have a better understanding of the immune system. We have to be able to kill a pathogen without designing a special drug for it. There has to be a way that your innate immune system can kill off any pathogen, bacteria or virus, based on new knowledge about the immune system. And I think I'm hoping that that's where the field is going to go to.
I think that one of the great things is that I think the attention to adult respiratory distress syndrome, which is the final common pathway of how people die of COVID, is getting the attention it deserves. And I hope that the attention will stay on that. If in fact we can come up with ways to keep people from dying in the ICU, the next pandemic won't shut the country down or need to while we're waiting for a vaccine. And I think, again, coming up with it, and if we continue to have more patient-centered ways to treat patients and ways to make sure that we separate, that we are ready. We know we've had the experience of a pandemic, kind of maybe we'll do as well as Singapore, and keep our cancer centers open and our new tools and keep that treatment safe and more streamlined. I think those are the things that we'll take forward and make us ready, and focus on making sure that the government invests in strategies for antibiotics, viruses, ARDS.
Yeah, no, thank you all. I guess we're at the top of the hour here. We could spend another hour here, I think, discussing this, for sure. So I want to thank all of you for joining us today, and wish you a great day. Thank you.
Great, thanks.
Thank you.
Thank you.